DPC is so hot right now. I think every consultant in America is pitching direct primary care and advanced primary care. And interestingly enough, there is a study from 2021 that's the most rigorous study that's ever been done on direct primary care that's starting to resurface. And it's actually a very interesting study. So, emergency room visits dropped 40%, incredible. Total healthcare utilization dropped 12.6%. And yet, the employer's net cost went up 1.3%. So why is that? Today, I'm going to walk you through what these models actually are, what the evidence really says, who they fit, what they cost, and which vendors are worth your time. Okay, first, let's start with definitions. I think our entire industry is really bad, including myself, about speaking in acronyms. We sound like a bunch of robots. So let's talk about what everything means first. All right, first, direct primary care, or DPC. This is a payment model. So an employer or an employee pays a flat monthly fee, usually around $50 to $150, paid directly to a primary care doctor. Now, the doctor's not going to bill your insurance at all. In exchange, the patient gets unlimited visits, longer appointments that are about 40 minutes instead of the average 13 to 16 minutes you'd get in a normal practice. Same day or next day access, wholesale priced labs, and generic drugs at cost. The panel sizes are about 200 to 600 patients per doctor. Compare that to 1,500 to 2,500 patients in a traditional fee-for-service. So that's the entire mechanism. Fewer patients, more time, and no insurance middleman. Okay, advanced primary care, APC. This is a delivery model. It's a little broader, fuzzier, intentionally so. APC is what you get when you take primary care and you bolt on a team. So you have nurse practitioners, health coaches, behavioral health coaches, healthcare navigators, plus you have claims data analytics, referral steering to high-value specialists, and population health management. DPC is a financing model. APC is a delivery model. They overlap consistently. Marathon Health literally says in their blog that APC builds on the foundation of DPC. I like DPC. It didn't start with a venture capitalist. It started with a Seattle doctor named Dr. Garrison Bliss. Nice last name, Bliss. So in 1997, Dr. Bliss did the math. The lowest monthly fee that could sustain a 600 to 800 patient panel was about $30 to $50 per month. He launched Seattle Medical Associates and filled the practice in just over a year. Pretty incredible. And then in 2007, he got Washington State to pass the law that created the legal term direct primary care. So meanwhile, on the employer side, something different was happening. In 1990, Harry Quadrasi, I think that's how you say his last name, he's the founder of Quad Graphics, opened a single physician clinic at his Wisconsin printing plant because his employees could not get appointments and his healthcare costs were exploding. So he just built a little clinic on site. That clinic became QuadMed, which is still operating today. So these big companies started catching on and they were like, oh, sounds great. So next was Pitney Bowes, then Toyota in 2007, a 9,020,000 square foot clinic in San Antonio. Then the famous one, Rosen Hotels in Orlando. Harris Rosen built an on-site medical center in 1991 that by 2018 had saved the company $340 million. And it was running about 50% below national per capita employer healthcare costs. So that's the APC lineage. It wasn't called APC yet. It was called on-site clinics, but the bones are identical. So fast forward to today, the 2020s have been the decade of consolidation. Amazon bought One Medical for $3.9 billion in 2023. CVS bought Oak Street Health for $10.6 billion. Walgreens spent $5.2 billion on Village MD. And then in February 2024, Marathon Health merged with Everside Health to create the largest dedicated employer APC vendor in the country. 680 health centers, 41 states, 2.5 million eligible patients, and about 630 employer clients. So when somebody pitches you advanced primary care in 2026, understand this. The category has about 35 years of operating history. It's not new, but the packaging is new. Okay, moving on. Here's the policy update that should be front page news in the benefits world, and it isn't. For the entire history of DPC, there was a fatal tax problem. If you had a DPC membership and a high deductible health plan, the IRS said the DPC membership counted as other coverage, which disqualified you from contributing to an HSA. So this was a real structural barrier because it's an ideal pair, right? Direct primary care for routine care and then your high deductible plan for catastrophic. But unfortunately, that was tax penalized for over a decade. So HR 1, the One Big Beautiful Bill Act, such a long name, signed July 4th, 2025, fixed it. So effective January 1st, 2026, just a few months ago, DPC arrangements no longer disqualify HSA eligibility. Monthly fees up to $150 per individual or $300 per family are allowed. DPC fees are now a qualified medical expense payable with HSA dollars. IRS Notice 2026-05 spells out the implementation rules. The only catch is the fee cap. So if your DPC practice charges more than $150 per month, you're back outside the HSA compatibility. This is probably the most consequential DPC policy change since the ACA. So if you're an HR leader, if you are a CFO, and you're offering a high deductible plan and thinking about a DPC, you absolutely should reprice that combo this year. Okay, here's the design question every benefits buyer has to answer. Are you wrapping DPC around your existing plan, or are you embedding APC inside of your self-funded plan? All right, let's go over option 1, DPC as a wrap benefit. You can keep your group medical plan. You layer on direct primary care on top as a supplemental benefit. The employer is going to pay the monthly membership for enrolled employees, and employees can still carry your major medical plan for big events, hospitalizations, specialist surgeries, any catastrophic costs. The optimal version of this, and the one that just got tax rationalized, is a DPC plus a high deductible health plan with an HSA. You have primary care that's unlimited and free through DPC, and then your high deductible health plan will trigger only non-primary care services. So you're going to reduce your specialist self-referrals, you're going to drop your ER use, and you're going to improve access. ICHRA is also compatible. You can reimburse DPC fees through an individual HRA if the fees are structured as medical services, not concierge access. So there's an important distinction that some vendors get wrong that you need to make sure your broker is double checking. Option 2 is APC integrated into a self-funded benefit plan. This sounds fun. And this is the bigger employer play. You contract directly with an APC vendor, Marathon, Premise, Crossover, QuadMed. For clinic services, you pay a PEPM per employee per month. The clinic gets your de-identified claims data so they can risk stratify your population, and they become the front door for primary care. They manage specialist referrals. They steer to high-value providers. This is where most of the actual cost avoidance happens. Not in the clinic visit itself, but in the downstream steering, because you have a whole clinic team and they're going to decide whether you're getting an MRI, who you see for your knee, where your colonoscopy gets scheduled. The navigation is key here. So one thing that nobody tells you, stop loss carriers. If your APC clinic reduces the claims following through your traditional fee-for-service feeds, your specific stop loss attachment calculations can get really weird. So make sure your stop loss carriers know about the clinic and accounts for it in the aggregate calculations. Some carriers now actually offer APC informed underwriting, but a lot still don't. All right, important side note. And here's where I'm going to be rigorous with you because the industry is not. There are 0 randomized controlled trials of employer DPC or APC. 0. So that being said, my arm looks so long. That being said, here's what we do know. The 2021 Milliman Society of Actuaries study, which is the most rigorous DPC employer study ever done. They followed 900 direct primary care enrollees against 1,100 PPO enrollees. And over 2 years, risk adjusted, total utilization dropped 12.6%, ER visits dropped 40.5%, and hospital admissions dropped almost 20%. The crazy thing is the net employer cost rose by 1.3%. The employer was paying the DPC membership fees and waiving deductibles. So the utilization savings didn't fully offset the new cost line. So DPC reliability reduces ER visits, but whether it saves the employer money is a design choice, not an automatic outcome. This is why design is so important in your benefits plan. Okay, the RAND study of Metro Nashville Public Schools. We had 6,000 teachers, 8 years of data, and we found that per person costs were $745 lower per year for clinic users. But, and this is the part where RAND was really honest, there was no detectable improvement in self-reported health status or in student achievement. So the cost story was real, but the whole person transformation story was not supported. Okay, next is the JAMA Network Open Study of a Southern California aerospace employer. They have 23,500 employees. So they found that primary users had 45% lower total PMPM costs. By the way, PMPM stands for per member per month. It's including dependents. So this is the strongest positive case for the study in the literature, but it is still observational. So when we look at this, we know that the emergency room reduction story is real. The chronic disease management story is real. QuadMed gets 75.3% diabetes control versus a 61.4% national benchmark. They get 86.4% blood pressure control versus 80.1%. So the overall employer cost saving story is real for well-designed programs with the right population. Quick detour, because this does matter. In 2018, Amazon, Berkshire Hathaway, and JP Morgan Chase launched Haven Healthcare. I know we all remember this. 1.2 million employees. Atul Gawande as CEO. This was the most sophisticated employer purchaser coalition ever assembled. And then 3 years later, it was gone. Even 1.2 million employees in a 330 million person healthcare system isn't enough purchasing power to force structural change. 3 different companies could not align their TPAs or benefit designs. The fee-for-service incentives were too embedded to dislodge from outside the system. So if Haven couldn't do it with that much firepower, you should be very skeptical of any single APC vendor claiming that they're going to transform healthcare. What they can do credibly is improve primary care access, reduce ER use, and manage chronic diseases. That is a worthy goal. Let's get practical. Who should be looking at this model? Who is this a good fit for? So for dedicated on-site clinics, that is a very long-term project. You need at least 1,000 to 2,000 employees at a single location for this to even make sense. Below that, the capital does not work. Now for shared near-site clinics where multiple employers share a facility, you can drop 100 to 500 employees as long as you're in the market with employer density. I am a big fan of near-site clinics, especially for ISDs. Great alternative. For DPC wrap benefits, any size, 25 employees works. There are off-the-shelf DPC networks via platforms like Hint Health that you can plug into without building anything. Okay, industries that fit: manufacturing, logistics, warehouses, geographic concentration, blue-collar workforce, high chronic disease burden, often unionized. Those are going to be your best fit. Hospitality and food service. Rosen Hotels is the prototype. School districts and municipalities. They have a stable, geographically concentrated population, and they're already self-funded. Multi-site retail in dense regional markets would also be a great fit. This is where it doesn't fit. When there's highly distributed remote workforces, the virtual APC partially solves this, but the referral steering benefit really weakens. Also, if you have a very, very young, low utilizing population, the membership really becomes a sunk cost. Fully insured employers with no claims data access, I mean, you can't measure what you can't see. Industries with over 50% annual turnover, not a good fit. The chronic care benefit needs time. The single biggest demographic driver of ROI is chronic disease burden. If your population is heavy on diabetes, hypertension, obesity, MSK, then APC has something to actually work on. If your population is a bunch of 28-year-old engineers who never go to the doctor, then you're paying for access that nobody uses. Okay, let's talk about what it costs and how long it takes. How long it takes to implement as well as actually see an ROI. So I'll give you the ranges. These are category level from industry reporting. So obviously we know actual contracts are going to vary by market and scope. Okay, the DPC membership wrap, $40 to $85 per enrolled member per month. If you get virtual only APC, it's about $15 to $40 per eligible employee per month. If you have a shared on-site clinic, that can be anywhere from $30 to $75 PEPM. If you have a dedicated near-site clinic, that can run anywhere from $50 to $100 PEPM. A full service dedicated on-site clinic was going to be $100 to $150 PEPM with capital costs being separate. All right, for capital. And this is something that I went through quite a bit at Kelsey-Seybold. For a dedicated clinic build out, that's going to run you, and I know this is a big range, but anywhere from $150 to $400 per square foot. Toyota spent $9 million for 20,000 square feet, serving 7,000 people. Rosen Hotels, and this is the move, they bought refurbished medical equipment at 10 to 15 cents on the dollar. Think about all of those clinics that have gone out of business. There's just empty real estate there. Okay, implementation. So a DPC wrap is going to take 60 to 120 days, closer to 60 days. A shared near-site clinic will take at least 6 months. A dedicated on-site clinic will take at least 12 months. And a full-service campus-like clinic is going to take you probably 12 to 18 months, all in. So there are a lot of different contract structures for these types as well. The flat PEPM, predictable, clinic bears utilization risk. Then there's cost plus. That's going to be very transparent and the employer is going to bear the risk. Then there's shared savings, which is best aligned incentives. That one's honestly the hardest to measure. And then capitated, full risk is on the vendor. The single most important RFP question is, how do you calculate savings? And was the baseline methodology reviewed by an independent actuary before the program started? If the vendor controls the denominator, the vendor controls the answer. And trust me, they will manipulate it if they need to. And this is where most of the dishonest math lives in this industry. Red flags to watch out for. Vendors who can't articulate independent savings methodology. In other words, they're overselling you. They're giving you performance guarantees with no financial teeth, engagement rate projections above 60 to 70%, multi-year contracts with no performance-based exit, vendors who refuse to share de-identified peer benchmarks. You got to look for all of this. So a quick tour of who's in the market. For pure DPC infrastructure, Hint Health is the dominant platform. They have about 2,400 DPC clinicians, 1.2 million members, and 7,200 employer sponsors. They are not a clinic operator. They are the operating system. Then we have Nextera Healthcare and Plum Health. Those are physician-owned DPC network. First Stop Health is also another great one that I'm hearing a lot about in my particular territory. Employer APC heavyweights. Marathon Health, post-Everside merger, is the largest player. They actually market 25 to 31% cost reduction. But that's a vendor claim that's not independently validated. Might be overselling a little bit. Premise Health, Warburg Pincus backed. Google actually moved to Premise from One Medical in 2024. So that contract switch is definitely worth noting. Crossover Health, they're tech sector focused. Apple, Microsoft, they're the ones that published the JAMA study. Apri Health, formerly Vera Whole Health, is now a Mosaic Health business unit. Rebrands have been very frequent in this industry, which I really don't like. Virtual first and hybrid, Firefly Health, their virtual first APC with embedded plan design, licensed in all 50 states. Nice Healthcare, visual DPC with in-home visits. They are really focused in the mid-market area. I hear about them quite a bit. Included Health, Galileo, Accolade, Transparent, they all overlap care navigation with primary care. So what you need to make sure you do, negotiate exit rights, make sure you have data portability and notice periods in every contract. Okay, here's my honest take. DPC and APC are not magic. They are real structurally sound improvements to a primary care system that the rest of the healthcare market has financially starved. They do reliably reduce ER visits. They reliably improve chronic disease control. And they sometimes, but not always, reduce total employer cost. The difference is in the design. So your biggest risks here are vendor consolidation, savings math that vendors control the denominator on, and selection bias that makes every published ROI number look better than reality. The biggest opportunity starting in January of this year, 2026, is the HSA fix. I think that's why we're starting to hear about DPC so much. If you're a benefits leader and you've been waiting for the policy environment to make DPC plus high deductible / HSA work, just did. Yay. I personally am a big fan of DPC. I think you should start measuring the impact closer to year 3 and 4. But in the long run, I think it's great.